genetics is creating a lot of buzz, and what I think we practice medicine, even breast medicine for that matter, very differently from what we used to about 7-8 years earlier. And it is changing. It is changing so rapidly that sometimes you think it is so hard to keep pace with. But I also think one of the good things about subspecialization is that you're able to hold on to that one piece and try to look at it at a molecular level. Because what I know is there are about 128 publications that come out every single day in oncology. So it is very tough to keep pace with it. So you cannot humanly do it. So you have to take care of smaller pieces to be able to do justice to it. So, so we want to know who is carrying a mutation, who should be tested. And it is not just the risk of, it's not just about the risk of developing breast cancer, it is also whether this mutation is actionable. And now with so many new drugs coming in, we know that there is a certain mutation, you can actually use a certain drug to take care of that mutation. And we are doing it in breast also. So there is a drug which can be used in germline mutations of BRCA1 and BRCA2. And it is being used. So most of these drugs are very expensive, quite toxic also. But for those people who merit these drugs, they are getting it. And the most well understood mutations in breast cancer are BRCA1 and BRCA2. So these mutations, while they are there, you must understand that the chances that one may pick up this mutation or has this mutation is very, very low. It is 0.25% of the entire general population, which means, which translates into 1 out of 400 people. So 1 out of 400 is not very small in terms of the numbers that we have. For some people though, the chances of BRCA mutation is very high. So genes are inherited, we know, and it is important to have a very detailed understanding of the family history, and only then can you ascertain what is the risk. If one of the parents has a BRCA mutation, this is very, very important. Everybody thinks कि अच्छा मेरी mother को तो मेरे को तो होगा ही होगा. It is not like that. 50% of the offspring will have it, 50% will not. Odds can also depend upon the ethnicity. So the most quoted ethnic group is the Ashkenazi Jews as far as genetics is concerned. They are the ones who are studied the most also. Because of consanguinity and a narrow gene pool, they have a hell of a lot of mutations. And it is not just breast cancer that they're dealing with, a whole lot of other cancers also. So their chance of inheriting a genetic mutation like a BRCA1 is close to 2.5%. This is 10 times over what is there of the general population. So this is what I meant. So this is how it is, the mother and the father, the affected father, unaffected mother. So there is an affected son, there's an unaffected daughter, unaffected son and an affected daughter. So 50%, because 50% gene material is coming from the father and 50% is coming from the mother. So obviously it gets divided in the next generation. So who should get tested? Overall odds are low, but there are certain criteria that has been fixed by various guidelines like the NCCN guidelines. If breast cancer is diagnosed under the age of 50, irrespective of the subtype, you would do a genetic testing. If somebody has been diagnosed with a triple negative breast cancer, irrespective of age, till a little while ago it was less than 50, then it was less than 60, now they've given up. They said no age, any age triple negative has to be tested for a mutation. Male breast cancer, any age. Any person with a bilateral breast cancer, anybody with a pancreatic cancer, anybody with metastatic prostatic cancer, any woman with breast and ovarian in the same person, multiple breast cancers in the same woman or in the family. Ashkenazi Jewish heritage, like I said, is a very significant history. And when we say significant history, we always tend to think, oh, mother ki taraf se, mother ki taraf. It's not just about the mother, it is about the father also. The father, so many times, you know, we have also evolved. There is a lot of times that you have not asked for the father's history. So 7 years ago, people would say, and we also used to accept it because we also, our understanding of genetics was also pretty poor. So we used to say, कि mother को नहीं है, तो we used to not ask father का क्या है. पता चलता है कि उधर बुआ को भी हो रखा है, दादी को भी हो रखा है. So you know, there could be that thing traveling from the father also. So these are the groups that need to be tested. And how does one get BRCA genetic testing done? So before any genetic test is recommended, very, very important to counsel the patient. So I don't write any genetic test on my prescription ever. This is something that I've told myself, that I will not succumb to this pressure of writing a test, because it is wrong to write a test without genetic counseling. And now genetic counselors, you may not have physical genetic counselors, but you have virtual genetic counselors. You can fix up free genetic counseling sessions with genetic counselors. They will do a very thorough job of it. I can do it. I can tell them, look, if it is positive, then you will need to be on close surveillance, or you will need to undergo these prophylactic surgeries. But sometimes this information can be a lot to take, because here I'm discussing your cancer treatment, and here I'm trying to shove some more information regarding prophylactic surgeries and all that. It doesn't work like that. I don't think it does. It is too much of information overload for a patient who's already grappling with a breast cancer situation. So I would get a genetic counselor to sit down. She can take her time. I said, don't rush into it. If suppose she's going for chemotherapy, she has time to ruminate, and she has the time to fix up an appointment with a genetic counselor who will draw up a pedigree chart. She will do a very thorough job. I can go up to 2 generations. She may find out somebody in the 3rd generation. And these tests take about 3 to 4 weeks to come back. So we don't really wait for these tests to come back before we make a clinical decision. Why I say that is, a lot of patients now, especially triple negative breast cancers, are getting chemotherapy before they undergo surgery. And it is a good thing in terms of genetics also, because they can get the genetic test done while they're on chemotherapy, and we can make the decision of surgery. What kind of surgery? Does she want prophylactic surgery, or is she still wanting to have conservation? We can have that discussion with that patient. So the results could be a positive, a negative, or it could be an ambiguous, or it could be a variant of uncertain significance. That is how a genetic report, simply stated, would read. So positive, we know that the patient is carrying a mutation. So negative means that she does not carry that gene mutation. She is truly negative, meaning her risk of developing breast cancer is the same as that of the general population. So meaning, it doesn't mean that she cannot have breast cancer. She could still have breast cancer, but that would be of a sporadic nature and not gene induced. So she needs to continue to do whatever screening or whatever she was doing. But if it is ambiguous or a variant of unknown significance, we have to keep an eye on this mutation. Because today in the gene database, we do not know what it means. But tomorrow, as the information is coming in, and it is coming in quite rapidly, it is possible that that mutation that you're seeing has grown in significance. As has happened to a gene mutation, which is called PALB2, which is the 3rd. It is also alternatively called as BRCA3. So PALB2 mutation is also making noises and vying for attention in breast cancer. But there, the risk of breast cancer is about 35%, as opposed to BRCA1, where it is 70 to 80% risk, and in BRCA2 it is close to 40 to 60%. And then there has to be a post-test counseling. Let her go back to the genetic counselor again, and she will talk about the various decisions. But then the reinforcement will come from the clinician. She has been there, she's heard all these terminologies of close surveillance, of prophylactic surgeries, of treatment decisions, and then she comes back to you, and then you tell her, so these are the options, you can choose which you want to, but you must tell her, when you're on close surveillance, whenever you see disease on an MRI, it is disease. And you will go through the same process of treatment again, which can be quite harrowing. So that is when patients decide, okay, possibly I will have a prophylactic surgery for the opposite side. So these are really life-impacting decisions, and none of them are easy. And I sometimes think how Angelina Jolie, who is a celebrity, who is a film star, for whom her physical appearance means everything, how did she make that decision of getting her breasts off in one go, with reconstruction, and then also her ovaries. So it takes a lot out of the person to make such decisions. So like I said, there are other mutations also associated with breast cancer, and we are slowly getting a handle on these ones as the information is coming in. So PALB2 is the 3rd most prevalent breast cancer gene, with an estimated 35% of women who are likely to develop breast cancer. Then there is CHEK2 mutation. It makes male breast cancer 10 times more likely to occur. Then there is something called CDH1, which is linked to lobular carcinomas. So whenever we get a lobular carcinoma, we ask for history, and there may be a history of stomach cancer, and that you can put that together and think that she may be carrying a CDH1 mutation. And then there are mutations in P10, STK11, P53. So there are various implications. So I have a patient who's P53. She's Lee-Fraumeni syndrome. Her son had osteosarcoma at the age of 8. 2 years later, she comes with a lump in the breast, and she is CA breast, and she's a P53 mutation carrier. So P53 is the most horrible of all these mutations. But in such patients, we have to remember, we have to limit the exposure to radiation. No X-rays, no mammograms, no CTs, no PET CTs. I saw a patient who came from Bangalore to show me as part of her follow-up. She's already had breast cancer. So when I was going through her papers, she said she was a P53 mutation, and I saw she had had a PET CT done, a mammogram done. So that's what I'm saying. We're all in the process of evolving, and we still do not know how to deal with these patients, but that patient should not have been subjected to any mammogram or a PET CT, because that's a lot of radiation and a risk for developing second cancers. So I always think, whatever you may get done, you can get interval cancers. If you suppose something really aggressive is to come, it can happen between 2 mammograms. So we can do what we can do, but we should accept what happens. So that is the way you have to live life. There is no other way, I think. So this is what is coming soon, which is the Women's Cancer Center in Defense Colony in possibly 3 or 4 months' time. An exclusive space for women, which is something that this has been my dream, and that is possibly the reason why I stepped out of Max, because I thought cancer treatment is not just about treating cancer, it is also about wellness. It is because I hear a lot, because I am very, very encouraged by the fact that you talk menopause. So why are we not talking menopause? Menopause comes with a lot of issues which we barely ever discuss with our patients. हम कहते ठीक हो जाएगा, अच्छा वो ना आपको hot flushes हो रही है, hot flushes बताओ ना क्या करना है. So we are not able to spend that time. So we want specialists who deal with menopause to be sitting with our patients and talking to them about how to deal with mood swings. And the thing is, now patients have started talking about it. Ki my relationship with my husband is pretty bad because I'm she says, I know I'm being horrible, but then it is not in my control somehow. I try to resist it, but then it's the hormones that is kind of wreaking havoc, the lack of hormones rather, but something has to be done. So whatever it is, I'm sure you have an Indian Menopausal Society, I'm sure you discuss all these things in a lot of detail, and I'm sure I would reach out to you to gain some insight from experts like you to be sitting in our center and advising patients who need this kind of support. So whether it is fertility, whether it is psychological issues, whether it is physiotherapy, movement issues, pain issues, somehow these are not addressed as well as they should be. And I'm hoping that with this center we should be able to address these issues. So that is the primary aim. Thank you very much.